and we'll see how we can interpret an ABG. So this is going to be an interactive session. So all of you can take a pen, paper, and since we are weak in mathematics, you can use the calculator. And I would like to confess that there is no intention to talk on the physiology or management of acid-base disorders. So we are just going to interpret an ABG that you are going to get. So what's an ABG? An ABG is an arterial blood gas which is drawn from an artery. It's an invasive procedure, so you should be very careful when you're going to take an ABG from patients who are on anticoagulants. And what it does, it helps to differentiate oxygen deficiencies from primary ventilatory deficiencies and primary metabolic acid-base abnormalities. So these are the things that you get in an ABG. I know you know all of these. And it's very important that you know the normal values of these. So pH is 7.35 to 7.45, PaCO2 is 35 to 45, and PaO2 is 70 to 100, and it is age dependent, and this value is at sea level breathing ambient air. Okay, and you will have other values also. Okay, fine. So now coming to PaO2, we are not very much bothered about PaO2. We see the PCO2 because PCO2 and bicarbonate, so that we know the compensation. So it's very important that you look at the PaO2. PaO2 depends upon the FiO2, and it's usually how many times the FiO2? So usually 4 to 5 times the FiO2. So if you are breathing room air, how much is your PaO2? Anybody can answer?
80 to 100.
100. So 21 into 5. So 100 to 105. And it depends upon the barometric pressure and the age. So you have to say that it is dependent on both the barometric pressure as well as the age of the patient. So this is the formula, age adjusted formula. 102 minus age divided by 3. So if the person is 60 years, what would be the PO2 that you expect?
82.
80. So anything below 80 in a 60-year-old is hypoxia. What about an 80-year-old patient? Yeah, we are weak at mathematics. So anything less than 60 is hypoxia in an 80-year-old. So that is that you can get from the formula 102 minus age by 3. And also you have to calculate the alveolar arterial oxygen difference. Okay. And again, how do you calculate that? You have this formula. Okay. So you can find you can calculate the alveolar oxygen by using the alveolar oxygen equation. Everybody should know this. FiO2 into the barometric pressure minus the water vapor pressure minus the PaCO2 by 0.8. What is 0.8? Respiratory quotient. How do you calculate respiratory quotient? In the mic.
Carbon dioxide eliminated by oxygen consumption.
Carbon dioxide eliminated by, so that is 200 divided by 250. That is 0.8. Okay, very good. So what is the normal alveolar arterial gradient?
So 5 to 25.
5 to 25. Good. And depending on the age, it is going to be different. So again, the normal is usually it will be less than this formula. Age in years divided by 4. You can add a 4 to that. Okay. So that is regarding PaO2. So always look at the PaO2 from your ABG. So what are the information that you can obtain from an ABG? You get the acid-base status, the oxygenation, and the carbon dioxide elimination. The indications are basically to assess the ventilatory status, the oxygenation status, and the acid-base status, and also to assess the response to an intervention. Now suppose you find the PO2 is low, you give some oxygen, you repeat the ABG and see whether the patient has improved. So that is to assess the response to any intervention that you do. So why don't you use a pulse oximeter instead of a ABG? Pulse oximeter, what is the principle?
Beer-Lambert's law.
Beer-Lambert's law. Okay. So the pulse oximeter, it does not assess ventilation and the acid-base status, while the ABG you can get all these three things. And pulse oximeter is unreliable once it falls below 70% because you cannot calibrate it to a human being with less than 70%. There are a lot of technical sources of errors. And before doing an ABG, any test you would like to do?
Modified Allen's test.
Allen's test. Allen's test. Hold it close so that everybody can hear. So, what are you testing?
Patency of the palmar arch.
You are testing the patency of the superficial palmar arch. Okay. So, even if the radial artery is not there, you can get the ulnar artery to collaterals will be there. But the color of the hand, it's varying for different people and you will not be able to see. Any other way you can modify it?
Using a saturation probe.
You can use a pulse oximeter and check the appearance of the plethysmograph. Okay. So, you can do it that way because it's available in your theater. So, before you do that, you can do all these tests. So, now we are not going to discuss anything else. We are just going to discuss the interpretation of ABG. So, you should have 9 sequential rules. The first thing is you should know the pH. So, if you know the pH, you can say whether the primary disorder is a acidosis or a alkalosis. So, what was the normal pH? 7.35 to 7.45. So, anything less than 7.35 is? More than 7.45 is? Okay. Rule number 2 is we should know from the ABG, you should know the PaO2, PaCO2 and the serum bicarbonate. So, after you look at the PaO2, pH, you look at these 3 values. And then rule number 3 is you should always establish that whatever data you have got is consistent. Nowadays, all these machines, they have quality checks. It's done automatically by the machine. But still, it's a machine. It can make mistakes. So, you can always check. What would be the test that you can do? Or the what equation you will use?
Sir, there are 2 ways of assessing it. One is based on the Henderson-Hasselbalch equation, which is pH is equal to 6.1 plus log of bicarbonate by CaCO2. The other one is 24 into PaCO2 by bicarbonate.
Yeah. So, you can use either the Henderson equation or the Henderson-Hasselbalch. Again, we are very weak at logarithm, so we will forget Hasselbalch. We will use only Henderson equation. So, Henderson equation is nothing but bicarbonate ion concentration into hydrogen ion concentration divided by PaCO2 will always give you a constant of 24. So, this is that equation. So, if you multiply the bicarbonate ion with the concentration of the hydrogen ion and you divide it by PaCO2, always you will get a constant value, that is 24. So, this is to check whether the data that you get are consistent. Now, we don't have some machines give you the hydrogen ion concentration, but some machines don't give you. So, how will you find out the hydrogen ion concentration of the pH value? It is by subtracting the last 2 digits of the pH from 80. So, these are just a few examples. Suppose calculated hydrogen ion concentration of 24. So, what would be the pH? One of the yeah, please.
7.53.
So, you just minus that 24 from 80. So, you will get 7.56. Okay. So, that is how you do. Another example, the calculated hydrogen ion concentration is 53. What would be the pH? You can do it either way. You can do the other side also. You people are very silent, so next for you.
7.37. So,
7.27.
7.27, sir.
So 80 minus 27, you will get a value of 7.27. So this is one way of finding out the hydrogen ion concentration from the pH values. Now this is reliable over a certain range. It is not acceptable for extremes of pH changes. So this relationship is only between 7.2 to 7.5. At the other ranges, it is different, but it is very difficult to remember all this. So we will minus it from 80. Okay. So coming to the disorders, you will look at the pH. If the pH is gone down, it is acidosis. pH has gone up,
alkalosis.
And then you have to look at whether the bicarbonate or the PCO2 has changed. So if the bicarbonate is at fault, it is a metabolic disorder. And if the PCO2 is at fault, it is a
Respiratory.
very easy. And then comes the compensatory changes. So first we will do simple acid-base disorders. In metabolic acidosis, what happens?
In metabolic acidosis, the pH decreases and bicarbonate also decreases.
So the bicarbonate decreases, causing a change in the pH to decrease. Good. And compensation?
Compensation is the PaCO2 also should decrease.
So PaCO2 should decrease. Okay. Next, metabolic alkalosis.
In metabolic alkalosis, the pH increases, bicarb will increase, and as compensation, PaCO2 should increase.
PaCO2 should increase. Okay. Now, the respiratory disorders, the acidosis and alkalosis have two things. It could be acute or it could be chronic. Okay. So coming to acute respiratory acidosis, what happens? In respiratory acidosis,
pH decreases and PaCO2 increases.
what about the compensatory changes?
Compensatory bicarbonate should increase, but in chronic it more increase in bicarbonate.
So why this in chronic the bicarbonate compensation is more?
Because the kidney takes more time for compensation in case of chronic diseases. So in both chronic respiratory acidosis and alkalosis, the change in bicarbonate will be increased. It will take more time for the change.
Okay, good. So kidneys take around 3 to 5 days for attaining full compensation. Whereas lungs, we are always keeping on breathing, no? So it will be very quickly you can compensate. Whereas kidneys will take a longer time. Takes around 3 to 5 days. Now next, what about alkalosis? What happens in alkalosis?
The pH increases, whereas the PCO2 decreases, and bicarbonate also decreases. Bicarbonate increases.
Bicarbonate?
Decreases.
So bicarbonate decreases. So if you look here, what can you see? The compensation is always in the same direction of the change of the primary variable. Upon acidosis, the pH has decreased. If you look at the PaCO2 in metabolic acidosis, the bicarbonate has come down. So the compensation is also PaCO2 coming down. So if you look at this picture, what you can see is that the compensation changes in the same direction as the change in the primary variable. Okay. So the compensatory variable always changes in the same direction as the primary variable, and compensation is more pronounced in the chronic respiratory disorders than in acute respiratory disorders, because the kidney gets more time to compensate. Right? Now, how do you know that a respiratory event is acute or chronic? From history, can you say the respiratory event is acute or chronic? Yes, from history you can say the event is acute or chronic, but it's difficult. So you use this formula. right? The change in hydrogen ion concentration divided by the change in PaCO2 is less than 0.3 in chronic, it's more than 0.8 in acute, and in between it is an acute on chronic. In other words, in an acute respiratory event, the change in pH will be 0.008 per millimeter mercury change in PCO2. This you have to by heart. Okay. For the change in pH will be 0.008 per millimeter mercury change in PaCO2. In chronic it becomes 0.003 for every millimeter mercury change in PCO2. Acidosis, PCO2 will go up. So the pH will come down. Okay. So I will give you an example. And before we go into the calculations, these are the standard normal values. pH is, what is the normal pH? For calculation purpose, it is taken as 7.40. PCO2 is 40, bicarbonate is 24, and anion gap is 12. So one scenario from this end. A 56-year-old man was found unconscious at home with a respiratory rate of 6 breaths per minute and pinpoint pupils. An ambulance was called and paramedics administered some naloxone. On arrival to the emergency department, his ABG showed the following: pH of 7.18, PCO2 of 80, bicarbonate of 26, PO2 of 50. Very good. So what we want to see here is this an acute event or a chronic event? From history we can say this is an acute event. Some poisoning with opioids, pinpoint pupil and all is there. But by ABG wise, can you say this is an acute event or a chronic event? So what is the change in PCO2? So 40 is increased. If it is an acute, what would be the pH? If it is an acute event, for the change in pH will be 0.08 into 40, that is 0.32. You minus it from the normal pH of 7.4 and you get 7.18 as the pH. That is in an acute event. If this was a chronic event, suppose a COPD patient who had collapsed and he was brought to the ED, his pH would have been 7.28. He would have compensated, right? Anybody who has not understood this, I can tell that once more. This is very important to how to distinguish whether the event is acute or chronic. Okay. So the change in pH, for every millimeter of mercury that has gone up or down, the pH will change by 0.008 in case of acute, 0.003 in case of chronic. That means the pH will be coming back to normal in a chronic. Will not be normal, but will try to normalize in chronic, whereas in acute it will be lower. Okay. This is okay. The next very important rule is you should obtain clinically relevant history. You should know that there are certain things which are going to be there for metabolic acidosis, for metabolic alkalosis, respiratory acidosis and respiratory alkalosis. So metabolic acidosis, diabetes, renal failure, metformin, diamox, diarrhea, all this will cause metabolic acidosis. Metabolic alkalosis, patient on RT aspiration, patient who is hypovolemic, whom you have given soda bicarb, who is having vomiting, all these patients will have metabolic alkalosis. So from history itself you can have an idea what the ABG picture will look like. Respiratory acidosis, COPD patient, post-op patient who is having muscular weakness, you have not reversed the patient properly. Respiratory alkalosis in tachypnea patient who is having tachypnea, who has hepatic coma or sepsis. So it's very important. So coming to the first group, which patient has better lungs? A has PO2 of 70, B has PO2 of 140, PCO2 of 36, all other things are normal, but the PO2 is double in B. So which patient has better lungs?
Sir, I would like to know whether the a patient is on oxygen supply support or not. If it is in the room air, I would go for
Okay,
A.
that's what I wanted to convey. Always you should get a history of the patient, whether the patient is breathing room air or whether he is having oxygen supplementation. He might be on a ventilator, he might be on 100% oxygen. So never interpret ABG just by looking at it. Always ask. We have a habit, people will give you an ABG and tell, okay, have a look. But always ask, if the patient is on a ventilator, how much FiO2 the patient is on. So never interpret without clinical information. So if you look at the picture now, you can say that the patient A has better lungs. Obviously, the patient B had higher PaO2, but he was on 100% oxygen. Okay. Next. Patient on room air. What is wrong? How severe is it and what will you do? He is on room air. FiO2 0.21, PO2 is 48, PCO2 of 40, pH is normal, bicarb is normal.
PO2 is reduced, other values are normal. So patient should maybe in hypoxemia. So we should supplement oxygen.
Yes. So from this, she has looked at the PO2 is down, patient is having hypoxia. So you have to increase the FiO2, give them supplemental oxygen or BiPAP, whatever is appropriate you should do. Next. Patient is on ventilator, FiO2 is 0.4, tidal volume you are giving 500, respiratory rate is 12. The PO2 is 128, PCO2 of 60, pH is 7.21, bicarb is normal. What is your interpretation?
So here the PCO2 is higher, it is 60. So patient is having a respiratory rate of 12. Maybe by increasing the respiratory rate, we can decrease the PCO2 and the acidosis can be corrected.
Very good. So here the thing is the PCO2 is very high. This is a case of respiratory acidosis, and so we have to increase the mechanical ventilation. And again you can calculate how much you can increase by using the RR into PCO2 old and RR into PCO2 new. And what should be the respiratory rate? You can calculate from this equation and find out how much you can increase. Instead of telling that, okay, increase to 20, you can have a better objective way of increasing the respiratory rate. Okay, so that is regarding basically how will you interpret ABG. Rule number 5 is you should know the compensation, and always remember compensation will never overshoot. There are certain rules of thumb which are there to interpret the appropriateness of compensation. Metabolic acidosis. What happens in metabolic acidosis? Acidosis, pH will come down, bicarbonate will come down, and compensation, the PCO2 will come down. It will be in the same direction. Okay, that is what you have to remember. And remember this formula, Winter's formula, that is PaCO2 is 1.5 times the bicarbonate plus 8. That is the classical Winter's formula, where you can predict the PaCO2 of a patient, the compensation of this patient. What would be the PaCO2 if the patient's bicarbonate is so much? Okay, so suppose metabolic acidosis, bicarbonate will be around 10 area. So 10 you multiply it by 1.5, so that will become 15 plus 8, around 23. So PaCO2 will be around 23. So PaCO2 has come down, the lung has compensated. In metabolic acidosis, the patient will be tachypneic. Okay. In metabolic alkalosis, the formula is PaCO2 is 0.7 multiplied by bicarbonate plus 20. Okay. There is no other way, you have to remember these formulas. Okay. Now coming to respiratory acidosis, you have to remember the 1-4 formula. That is, for every 10 millimeter mercury increment in PaCO2, the bicarbonate will increase by 1. That means for every 1 millimeter mercury increment in PaCO2, the bicarbonate increase by 0.1. Okay. In chronic anemia, it becomes 4. So this is 1-4 formula for respiratory acidosis. What about alkalosis? It is 2-5. Okay. but here it will fall. Acidosis, it will
carbon dioxide increases.
the bicarbonate will fall here. Okay, Matthedu?
Increase.
PaCO2 will fall. So this is again 2 for every 10, and in chronic it will be 5 for every 10. The other in acidosis it was 1 for every 10 in acute and 4 for every 10 in chronic. In alkalosis it is
2 for acute.
2 for every 10 and
5 for.
so 2, 5 and 1, 4. So I think all of you might be thinking, what is this? What's going on? So we'll practice. Okay. All of you can do the red ones, and the other people can do the white ones. So the first team can do the first one. You can do the third one. You can do the fifth one. You can do the seventh one. You can do the ninth one. And for the audience, quiz, fourth one. Forget the PaO2 and SaO2, no time. Only 20 minutes left. Anybody ready? Audience? So the first one is, ready?
So pH is 7.48. So it indicates towards alkalosis,
Good.
alkalemia. So I'm looking at the PCO2 and bicarbonate. PCO2 is 32, is slightly lower side by considering 40 as a normal range.
Yeah.
And the bicarbonate is looking normal. And PaO2 is 90.
Yeah, forget PaO2.
Okay. So this is a respiratory alkalosis, sir.
So it's a respiratory alkalosis. Second one, the third one.
It is metabolic acidosis because pH is 7.3, it's reduced, and PaCO2 is normal, and bicarb is reduced, uncompensated.
Yes. What about audience? Audience? Okay, audience last. Next. Who is next? Fifth one.
Sir, pH suggests alkalosis, and carbon dioxide is normal, and bicarbonate has gone up, so it is suggestive of metabolic alkalosis.
Very good. Next. Seventh one.
Metabolic alkalosis with compensation.
I don't know, somehow everything is metabolic alkalosis. Is it? Is it compensated? 7. It is a compensated metabolic alkalosis, because you can see that PaCO2 has
Increased by
gone up. And last, the rapid. This is rapid interpretation of ABG. Yeah. Very good. So we have completed this one, and for the fourth people, audience, you have done well. Compensated respiratory disorder. Somebody told from the audience. So this is, it's not magic understanding ABGs. All it takes is little practice. So over the next 15 minutes, okay, some questions. Anybody has any questions till now? It has to be cleared, and then only we can go forward. Only 15 minutes. Okay, nobody has, so I will ask questions. ABG versus VBG. Can you use a VBG?
Yes, we can.
Is VBG, tell me.
VBG can be used in case of ABG is not able to do, considering the fact that pH can be considered. pH will be more or less same.
Yes.
And
but PCO will be higher, no? So there is a small change, 0.006 change will be there. Yeah, okay. Still, we can still use a VBG to manage, because we maybe getting an ABG might be difficult. So we can use, except in cases where like in shock states, it might not be reliable. What about hematocrit? Any change in hematocrit from a VBG and ABG, which will have a more hematocrit? So this is homework for all of you to go and find out. The hematocrit will be more in VBG samples than in ABG samples. Okay? Because of hamburger phenomenon. You go today and see what that is. Now transporting ABG samples. How will you transport ABG samples? Next.
Before transporting, the air bubble should be removed and it will keep on ice pack.
Ice pack. Why you want to keep on ice pack?
WBC.
WBC are active and
Metabolic-
it can
metabolic
utilize the oxygen. But this is only needed if you are going to have more than 20 minutes delay in doing the sample.
Analysis.
Okay. Suppose there is an air bubble in your syringe. Will it change the ABG values?
Yes, sir. It will change the air bubble. It will change the value. The amount of oxygen will be shown as increase. And carbon dioxide levels will be shown decrease.
Why?
Air bubble contains.
Air bubble, the PO2 will be around 100 to 150 and the PaCO2 will be 0. So this can diffuse. Depends on the size of the bubble, the number of bubbles, all that complications. Okay. Next. What about heparin? You use heparinized syringe, right? So what about heparin?
Dilutional effect will be there if it is less than 2 ml.
Dilutional effect can be there. Then any electrolyte that can change?
Sodium and
Sodium.
Why sodium?
Sodium heparin we use.
So our heparin is heparin sodium. So sodium sample, very good. You don't have a question. So we'll go to the case number 1. We have just 30 minutes, very fast, rapid round. A 4-year-old child with chronic renal failure presents to the emergency room with history of increasing azotemia, weakness and lethargy. The labs reveal raised renal indices. Can you tell an acid-base disorder is present or not in this child from the history? Yes, why? Patient is having?
chronic renal failure.
Patient is modestly hypertensive, tachypneic, has azotemia, right? And the renal indices are high. So you can, mentally you can prepare yourself, okay, this patient is going to have some problem. So we should know the pH, PaCO2. So okay, please, can you interpret? pH is 7.33, PaCO2 of 24, bicarbonate of 12. Yeah. Data are consistent, sorry. That's the first step that you should do. Okay. Yeah, tell me. It is consistent. I have done it. Okay. No, you tell me the remaining part. 7.33 PaCO2 of 24 and bicarbonate of 12. Okay. Acidosis is correct. So bicarbonate has moved in the same direction as acidosis, or PaCO2 has moved in the direction of acidosis. Which is the primary problem? Fast. No time. Bicarbonate. It is bicarbonate. PaCO2 is 24. It has gone down. You will not get acidosis. You will get alkalosis. So the primary event is bicarbonate coming down. Okay. So it is acidosis, and it is primary disorder is metabolic acidosis. Now somebody calculate compensation. Bicarbonate is decreased by 24.
Sir,
it is
this
12 only. So
yeah. So this is metabolic acidosis. So 1.5 into bicarbonate gives the expected PaCO2. So
values. Okay, here. Okay.
So
1.5
into 12 plus 8 plus or minus 2.
Okay, good.
Will
So
give 18, sir.
it is, since PaCO2 is 24, compensation is appropriate. Correct? So you have found out the PaCO2. How did you find out 1.5 into 12 plus 8? 1.5 into 12 atraya 1.5 means 3 into 12, 36 divided by 2, 18, 18 plus 8, 26. Okay, wonderful mathematics. So, approximately it is correct. Okay? Alle? Yes. So, this is a case of metabolic acidosis with appropriate compensation. Okay. The next thing, if the data are consistent with symbol disorder, it does not guarantee a symbol disorder. You have to examine the patient's history. And when compensated responses do not lie within the accepted range, by definition, a combined disorder exists. We have 9 minutes. Case number 2. 15-year-old female is brought to the emergency room in an obtended state. Okay. As per her family, the patient is malingering, weakness for last 2 months. But a complete physical examination has demonstrated decreased deep tendon reflexes symmetrically without any other abnormal findings. Examination shows shallow tachypneic respiratory effort. Who is next? Next. So the PaCO2 is 40, bicarbonate is 7, pH is 6.88. It is consistent. The data is consistent. Now, can you interpret? Second thing.
Metabolic acidosis.
It is metabolic acidosis, right? Everybody agrees? Because pH is down, bicarbonate is down, and PaCO2 has gone up. PaCO2 is normal, sorry.
Respiratory acidosis also there.
And what about compensation? So answer is metabolic acidosis is correct. Next you will look at compensation. Metabolic acidosis formula 1.5 into
7
7
plus 8.
plus 8. 1.2 into 7 again. Please tell me, I don't know.
18.5.
Answer is?
PaCO2, expected PaCO2 18.5, but here PaCO2 is 40. So
40. So expected is 18, approximately 18 aanu, but here it is 40. That means there is some
respiratory acidosis.
there is some other problem which has caused the PaCO2 to go up. So that means the patient has an added respiratory acidosis. So very good. Okay. I will give a small scenario to the next team. 7 minutes, very fast. A 17-year-old patient presents to the AE emergency room, complaining of a tight feeling in her chest, shortness of breath, as well as some tingling in their fingers around their mouth. They have no significant past medical history. ABG is done. The sister said, okay, we will do ABG. ABG was done. pH 7.5, third team. PO2 105, PaCO2 28, bicarbonate 22. Okay, third team.
So pH is increased.
So it is alkalosis.
And PaCO2 has fallen.
PaCO2 has fallen.
So it's respiratory alkalosis.
Respiratory alkalosis. You expect the bicarbonate to fall. Whether it has fallen?
It has fallen.
It has fallen. Okay. So what is this? It is a case of
respiratory alkalosis.
Respiratory alkalosis. Why this tingling and all? Why tingling? Around tingling in fingers, around mouth? Hypocalcemia. Why hypocalcemia?
Binding of calcium in acidosis.
Yeah, in alkalosis, what happens? Metabolic alkalosis? Okay, you can go and read. So, if you have a patient with metabolic alkalosis, always check the urinary chloride. If urinary chloride is less than 20, the patient is chloride responsive. And you can give some sodium chloride, normal saline, in your ICU, patient will improve. But if the urinary chloride is more than 20, it is chloride resistant. Okay, so you will have to give something else. We are not dealing with treatment. You have to go and read. So next we come to case number 3, 6 minutes. 16-year-old male with sickle cell anemia, hemochromatosis, cirrhosis, presents with a several-day history of vomiting. At presentation, patient is hypotensive, orthostatic, and confused. So what are from this history, which team is next? You. From history, what all acid-base disorders you can anticipate?
MSS is there, so metabolic alkalosis component may be there.
Very good. So,
Hypotension is there, so maybe lactic acidosis.
lactic acidosis, very good. Fast. So MSS, loss of, you have metabolic alkalosis, patient is vomiting. Hypotension, he told, lactic acidosis. Next, cirrhosis, where is lactate metabolized?
Liver.
Huh? Liver. So again lactic acidosis. Sickle cell anemia, hypoxia, again lactic acidosis. So definitely this patient you can say will have metabolic alkalosis and metabolic acidosis because of lactate. So baseline information you have is 7.55 PSU out of 66. And these are the sodium, potassium, chloride, bicarbonate. Okay, theme number 5. Any ideas? Data is consistent, we have checked. You can write it down. I am going to change the slide. So, what is the primary abnormality? pH is 7.55. 7.55 is alkalosis. PCO2 is 66. Bicarb is 56. So this is metabolic alkalosis, right? Primary abnormality is metabolic alkalosis. So when metabolic alkalosis is there, what happens? The PCO2 will go up. So we will see the. So this is metabolic alkalosis due to MSS. Is compensation appropriate? What is the formula? 0.7 into bicarbonate plus
22.
21.
22.
21.
22. Okay. I'm sorry, what is the value?
60.
16. Okay.
60, sir.
60.
60. But you are having
66.
66. But okay, we will adjust. Okay. So the compensation appears appropriate. Okay. But you have multiple risk factors for lactic acidosis. But that is not being shown on the ABG. So what will you do?
Anion gap.
Delta gap.
Anion gap. So you will check the anion gap to find out whether there is a, because from history you have decided this patient has metabolic acidosis. So could there be a concealed? So what is the anion gap?
Here it is
20.
20. Okay. Here the anion gap is 20. So it is definitely anion gap is increased. And that implies the patient has a hidden metabolic acidosis. So this is a combined metabolic alkalosis and metabolic acidosis. So always calculate anion gap and the delta gap. This is often the only sign of occult metabolic acidosis. And you know the causes of, I am not going into all this, causes of anion gap: nagma, normal anion gap; hagma, high anion gap. You have your own formula, your own mnemonics, mud piles, hard up, all that. Okay. So I am not going into all that. No time. But again, you should remember that suppose there is hypoalbuminemia in patients with hypoalbuminemia, this is factitiously dropped by 2.5 to 3. So if the patient's 1 gram albumin from 4 is decreased, you always add 2.5 to 3 in the anion gap. Okay. Okay, we don't need all this. Okay, last case. A 3-year-old is brought to the ER at 3 a.m., stuporous and tachypnic. History is that the parents say that they have cleaned their medicine cabinet. An ABG is drawn. The nurses are very good. They have drawn the ABG. And the data is 7.53 PSU of 12, bicarbonate of 10, sodium, potassium, chloride, everything is given. Anybody wants next team, Ara? No team wants.
Respiratory.
So data is consistent. So what is the primary disorder?
Respiratory alkalosis.
So respiratory alkalosis. So compensation. Is compensation appropriate?
Acute or chronic, find out. Respiratory, we should find out whether it is an acute event or a chronic.
We will, no time.
Acute.
Correct, you're correct. You have to check whether it's an acute event or a chronic event.
They should.
So, but this is because the it is ingestion. So this has to be a acute event. From history, we have decided it is acute. So here, how much the PaCO2 is?
12.
How much was the PaCO2?
12.
12. How much you expect in acute respiratory
40.
alkalosis?
40.
The PaCO2 should have decreased by 30. Less.
CO3.
Decreased by 30. The bicarbonate should. Okay, time up. So here we have a superimposed metabolic acidosis, right? Okay. So this is a case of combined respiratory alkalosis with metabolic acidosis. Metabolic acidosis is seen in salicylate ingestion. What do you get? You get a high anion gap metabolic acidosis. Okay, so we will stop here. One more final slide I will show you. Suppose you have a high anion gap acidosis, also we look for gap acidosis. Gap is nothing but the difference in the anion gap divided by the difference in the bicarbonate. If it is if it is less than 1, that means you have a added normal anion gap acidosis, and if it is more than 2, you have a concealed metabolic alkalosis also. Since we don't have time, we are leaving all that, but this is very important. This one last question. A 64-year-old man is admitted to the ER with central crushing chest pain. As the nurses are getting him attached to ECG, he has a cardiac arrest. CPR was commenced immediately, and after 6 minutes he regained spontaneous circulation, began breathing. ABG on 15 liters of oxygen, pH is 7.25, bicarbonate is 16, PCO2 of 60, PO2 of 60. Anybody?
So respiratory acidosis.
It's
Here you can see pH is down, so this is an acidosis. But you look at bicarbonate, it is also down. You look at PCO2, it is also down. Both are down. So which is the primary disorder? Here what you do is you see the percent change. What is the percentage change in bicarbonate? So 24 minus 16 by 24. 8 by 24, that is 1/3, 33%. What about the change in PCO2?
50%. 50%.
50%. So which is the primary component?
respiratory.
It is respiratory acidosis. So this is primary component is respiratory acidosis. The next, because it is having a more percent change. Okay. The next event is the arrest.
Followed by
And he has gone having hypotension and all that because of the arrest. He is having metabolic acidosis also. So this is very important. Find the percentage change. So finally this slide very important. Remember this. First check oxygenation. You forgot to tell oxygenation. PO2 was low. 15 liter of oxygen. You will expect higher PO2 but post arrest. So always look at this. Look at PO2. If it is less with normal PO2, it is type 1 respiratory failure. PCO2 is more, it is type 2 respiratory failure. Look at the pH, acidosis, alkalosis, all that we have discussed. Okay. So, valuable information can be gained. Remember that it is only part of the patient assessment. Always examine the patient, get the history. Okay. So, it's not magic understanding ABGs. Just takes a little practice. Thank you.